everyone. Good morning, good afternoon, or good evening, depending on where you're logging in from. Welcome to today's GANSID Congress 2024. In this session, we'll be hearing from 3 speakers who I will introduce shortly. The agenda will start with some housekeeping rules, which I will go through right now. We ask that you save your questions, thoughts, or concerns until the latter portion of our session, where our guests will be able to answer questions individually. We kindly ask that you respect the learning be done in the space by abiding by the following housekeeping rules. Your microphones have been disabled for the duration of the webinar. If you would like to ask a question, please do so by putting your question in the chat or the Q&A function, or by raising your hand at the end. We'll try our best to answer all questions during today's session. Translation captioning is provided, and the information is provided in the ebook for the Congress. Please use respectful language in the chat. Please do not post other material unrelated to today's discussion topic, and please keep discussions and comments on topic as much as possible. The GANSID does reserve the right to pause the session or to seek removal of participants who do not abide by these rules. Thank you for your understanding and agreement to positive participation. And with that, I will move on to introducing our wonderful speakers. We have changed the order slightly, so we will be starting with Dr. Shipra Kaicker on the topic of increasing access to factors in hemophilia. And I'll tell you a little bit about Dr. Kaicker before she joins us for her presentation. She is a clinical associate professor of pediatrics and a pediatric hematologist, oncologist, and full-time teaching faculty member at Weill Cornell Medical Center. She has practiced clinical medicine and taught and mentored medical students, residents, and fellows for over 20 years. She's particularly interested in global health and in improving the care of children and adults with hematological and oncological disorders in poorly resourced settings. We welcome you today, Dr. Kaicker, and over to you.
Thank you so much, Dr. Verhofstadt. I hope I said that correctly. I will begin my talk. I'm going to start sharing my slides. I hope you can see my slides.
Yes, we can see everything.
Perfect. So I was tasked to talk about increasing access to factors in hemophilia. So I'll begin by a little bit of a brief background to say that the World Federation of Hemophilia, which is a very large global organization based out of Canada, does this annual global survey and reported that close to 500,000 people live globally in the world with inherited bleeding disorders. And this is 2022 data, out of which almost a 3/4, 75%, live in the developing world. The same survey also reported that there's about 11 billion units of clotting factor that are available for hemophilia A and B annually. However, only 19%, or about a fifth of them, are available in the low and middle income countries. So as you can see, there's significant disparities in care of patients that are living in developing countries. More so, the patients that live in resource-poor settings receive a delayed diagnosis for their hemophilia and often inadequate factor replacement to treat or prevent their bleeds. Furthermore, very few patients in low-middle-income countries are actually on primary prophylactic therapy to prevent bleeds. And this really is the standard of care now for both severe hemophilia A and B. We often start very young children on prophylaxis to prevent bleeds from happening, because we know that long-term bleeds will cause all kinds of disabilities. Thus, despite several exciting and innovative new treatments, such as long-acting factor products, non-factor agents, and now gene therapy, hemophilia continues to cause significant morbidity and mortality and a very poor quality of life for people in many parts of the world. The main barriers, and there are many, to care are, first of all, delay in diagnosis because of poor recognition of symptoms and signs, lack of having good coagulation lab testing, So you really need to have a good lab that can make a correct diagnosis of whether it's hemophilia A or B or severe von Willebrand's disease or another rare clotting factor deficiency before you can institute the proper treatment. Inadequate provision of both factor and non-factor treatments, primarily stemming from a segmented healthcare infrastructure, no health insurance many times, as well as a lack of allocation of required resources and inconsistent support from local governments and policymakers, where there's a lot of competing priorities in terms of where to allocate healthcare funds. So this graph right here shows, it's from Blood in 2022, the journal Blood, that many patients with hemophilia are actually dying from preventable causes. And so this was a study that was done in the state of Kerala in India. They gathered about data from about 1,000 patients with severe hemophilia, A and B. And this was a study conducted over 7 years. And as you can see, this pie diagram, a good majority of these patients were dying from bleeding episodes. So almost 41% were dying of intracranial bleeds, about 8% from gastrointestinal bleeds, with a smaller chunk from hemoptysis or bleeding from the lungs, as well as bleeding from wounds. If patients had received tainted blood products, so this is a non-bleeding mortality, there was a significant amount of hepatitis C-associated liver failure, and a smaller chunk were from causes that were not directly related to their hemophilia. So back in about 2008, as a practicing pediatric hematologist in the US, and with my sort of passion for global helping kids in poorly resourced environments, I started volunteering with the Hemophilia Society of Delhi. And you can see here, I was quite aghast when I saw the kind of deformities that very young children were developing very early on in life. So these are young boys that are already having not what we are typically used to seeing in the developed world, which is acute hemarthrosis, but in fact, chronic joint disease or chronic synovitis, which is not easily treatable by just giving factor infusions, and often requires secondary prophylaxis, intensive physiotherapy, and even potentially some kind of surgery or some kind of invasive procedure down the road. Again, these are pictures from taken from Hemophilia Society of Delhi, where you can see, this young man came with what was a pseudotumor which is a very rare complication, nevertheless, but again, from recurrent bleeds into his thigh, and really looking like a tumor. And this little boy here clearly had an acute compartment syndrome in his arm and now had nerve damage with a Walkman's ischemic contracture. So really showing the burden of disease when it's not adequately treated. So what are the things that can be done? So really, a lot of governments try to provide universal health care despite financial hardship to its citizens. However, given the health budgets, the agenda of where they're going to allocate these resources, can be a little tricky. And hemophilia is an expensive disease. Clotting factors are very, very expensive. But I think there are many things that can be done. And this is a very nice schema that I adapted from a nice paper by Dr. Johnny Malangu and others, talking about diagnosis and treatment challenges in low-resource countries in hemophilia this year. And they talk about how perhaps we can really start with early recognition of abnormal bleeding by training community health workers and healthcare personnel that are not that familiar with bleeding disorders, so that they make timely referrals for patients with bleeds. Training that the World Federation of Hemophilia and others are providing to really train personnel and have workshops for good quality coagulation lab facilities with good quality controls, and labs that cannot be done at a basic level can then, having a referral pattern for centers that are able to, for instance, test for inhibitors and such can be offered. Point of care testing for bleeds using ultrasounds is something that people can be trained to do. And in addition, I think one of the biggest challenges that I saw when I was there was that patients were actually traveling for hours many times to get the factor concentrates that they needed. And really, their geographical location was a very big part of them not being able to get to a center to get the factor on time, or the traveling really was an impediment to getting the bleed treated appropriately. And then the last step, of course, is referral to hospitals with physicians that are trained in the management of bleeding disorders, who really can provide a comprehensive care, but essentially act as more like consultants, helping to manage the patient, potentially living far away with their primary providers. And so, again, from the same paper, they talk about how in many lower middle income countries, healthcare is really kind of like a health pyramid. So at the base of the pyramid are really the community level workers that are within the communities. And one can train them as part of, when they do maternal and neonatal health, they can be trained to recognize what is abnormal bleeding, particularly if it's occurring in, other family members. You can have nurses at the other level where they can maybe be trained to treat an acute bleed and then refer to a hospital. You don't have to be a trained hematologist to figure out how to treat a bleed if you are consulting with a specialist. And so perform at least routine hemostasis, infuse factor, and then refer patients to a referral center. And really on the top of the pyramid lies the reference center. And then again, they talk about how all the stakeholders are very important for this disease. So people with hemophilia and patient organizations, I think, are critical in advocacy and getting involved. And I think for a lot of chronic rare diseases that are expensive to treat, patient advocacy groups play a very, very important role, to ensure availability of treatment, acceptability, and affordability. Similarly, the healthcare providers in the country can create protocols that are country specific. They don't have to give hemophilia at factor concentrates at high doses like is done in the developed world. And I think there's work showing that giving factor concentrates at lower amounts can be pretty efficacious. And participating in clinical studies and shared decision making, educating patients. There's a lot of things that the healthcare provider can do for availability, acceptability, and affordability of treatment. And of course, the funders, right? So the government and the private funders, getting organizations to fund patients or support patients as part of their corporate efforts, advocacy within the government, and the government really taking interest in this disease and providing specific funding. I think these are all critical pieces to successful hemophilia care within a country. So I want to briefly move gears to what is out there that can help these patients. I'm sure if all of you are aware of the World Federation of Hemophilia. This is a nonprofit organization dedicated to improving and sustaining care for people with inherited bleeding disorders around the world. It was founded back in 1963 by Frank Chanbel, who himself was a gentleman with hemophilia. It's headquartered in Montreal, Canada. It's one of the largest, or it is the largest global organization for inherited bleeding disorders. And now its presence is in 152 countries worldwide. The World Federation of Hemophilia does many things. It provides annual disease-specific statistics that it collects from different countries. It provides a lot of free education and training to healthcare providers, physicians, nurses, physiotherapists, lab personnel. It provides factor and non-factor replacement therapies by liaising with the pharmaceutical companies. And it also measures impact measures worldwide. By doing so, a World Federation of Hemophilia has really raised a lot of awareness, and it also liaises with local country organizations and incentivizes local governments to invest in bleeding disorders. And then it's also the largest distributor of donated products through its humanitarian aid program. So a little bit about the World Federation of Hemophilia Humanitarian Aid Program. It really is built around the fact that you really need to provide access to patients that don't have access from their governments for safe treatment and care. And as you can see over here, World Federation has donated almost 2.1 billion international units of factor and about 11.6 million milligrams of non-factor replacement therapies. And so really countries that qualify for these donations, so it's not an individual donation. The support goes to a national member organization or a hemophilia treatment center. And to qualify, the country generally needs to have a per capita use of clotting factor of less than 1 IUs to be able to qualify, and they need to sign a memorandum of understanding with the aid program. Additionally, World Federation has many other very great programs. So there's a program that you can look up on their website called the Path to Access to Care and Treatment Program, which is going to be used to identify at least an additional 20,000 patients with inherited bleeding disorders, because there is really there's probably a lot of patients out there that have not been diagnosed. And so really finding these people out there in the communities, again, improving care by training personnel and increasing government support to establish and expand national bleeding disorder care programs within the country. The goals of the World Federation of Hemophilia humanitarian aid program were launched in 2015. There were 5 fundamental goals, and really it was to reach most countries that meet this inclusion criteria that I just talked about, and to treat as many people with hemophilia as possible within a country, to increase the diagnosis rates, engagement by the local governments, provide skills in management and care to the local healthcare providers, really pushing to do prophylaxis for children before they develop debilitating joint diseases and other complications, and to decrease mortality and improve quality of life. And then they actually added a 6th goal, which I think is a critical goal, where you want to empower the recipient countries to achieve sustainable and independent management of bleeding disorders within their own country's environment. And so the global impact, like I mentioned before, is amazing. You can see in 2024 alone, this program supported close to 14,413 patients, treated a large number of patients, about 28,000+, aided in plenty of surgeries. And again, I think very interestingly, caring for 896 children under the age of 10 by providing them the means to get prophylaxis, which is what we do in the developed world. This is another wonderful organization that I want to bring your attention to, and I have been involved with them for many, many years. Laurie Kelly is the founder. She's actually a philanthropist, a mother of a hemophilia patient, as well as a businesswoman. And this is a US-based nonprofit serving the needs of global hemophilia communities to raise public awareness, identify children and youth with bleeding disorders who need aid in developing countries. She also has a program whereby you can provide direct financial support to beneficiaries. So I was supporting one of her a couple of boys through this program, the Save One Life program. And I still follow up with those boys, and they're doing really well, which makes me very happy. So a lot can be done from an individual standpoint as well. And to really offer sponsors and donors an opportunity to make a direct difference one-on-one in the lives of people with bleeding disorders in developing countries, and to form those personal connections, which are really heartwarming. Laurie also has usually personnel or people that she has in every country that she partners with to move this program forward. Again, through her foundation, they have something called Project Share, which is basically stands for Supplying Hemophilia Aid and Relief. It's a humanitarian program whereby many even institutions can donate factor, people can request factor. And so you can see since 2002, Share has donated more than 167 million units and 9,745 milligrams, approximately $167 million worth of factor to thousands of patients in many developing countries. And they do that by liaising again with pharmaceutical companies, but also with US treatment centers, so that if there's unused or unwanted products, they take that and then they're able to provide it to people who need them. And I'm sure many people many providers in the developing world will identify where patients moving from, say, a factor product to Hemlibra may have factor product lying around, not sure what to do with it. And so I encourage you to look, if you don't know about this organization. It's a wonderful organization. Twinning partnerships, again, the World Federation of Hemophilia has been having, and I was very fortunate to participate in this back with one of our earlier speakers yesterday, Dr. Stockman from Canada. And so our twinning was with Hemophilia Society of Delhi. And so really over a 4-year period, the idea was to identify gaps in local infrastructure, provide educational support and capacity building, and help with the twinning partner with self-dependence and self-reliance. A lot of what we focused on was really education of the local personnel. I continue to do this work. I now work with a wonderful hematologist, again, close to Delhi in a state called Uttar Pradesh. This is Dr. Neeta Radhakrishnan. She is the head of pediatric hematology oncology at the Postgraduate Institute of Noida, which is again in India. And with her, you can see standing this lady here, who's the secretary of that society, her son who has hemophilia, and then this gentleman here that I want to bring your attention to, Mr. Rajan Chaudhary, who himself has hemophilia and has now opened a trust, which I really like this name. It's called I Dream to Trust. And what he does is basically identify individuals within the community who need factor desperately. And I keep in touch with them through WhatsApp. So social media is so helpful in this regard, where I find out, who needs the factor, how quickly can we get it to them. And so with the permission of these patients, I get feedback as to, who got factor for what kind of bleed and what did they get. And perhaps this is not treatment that is everything that I would do, say, for my patient in New York, but certainly as much as one can help, you try to, and you can do it really on a one-by-one basis, which is really nice. I think hemophilia patients with inhibitors in the developing country face a much bigger challenge because that exponentially increases the cost and quality of life becomes very poor with early mortality. Again, limited availability of these very costly bypassing agents, recombinant factor 7A and activated prothrombin complex concentrates. So really, the approval of drugs like emicizumab, which is a bispecific monoclonal antibody that binds to factor 9A and 10 and really bypasses, has really revolutionized care even in developed countries for patients with hemophilia A with and without inhibitors. The best part about this is it can be given as a sub-Q injection. Obviously, the availability is limited in the developing countries because of its cost. However, I want to really share this exciting slide where some people think that this could be a game changer in lower middle income countries because it is given as a sub-Q injection, so you don't have to do an IV. It can be dosed up to every 4 weeks. And there's less stringent storage requirements and the possibility of being able to give it to people in remote areas because they can do sub-Q injections. So there's already data emerging that's showing that low dose emicizumab prophylaxis in hemophilia A, both with and without inhibitors, can be done successfully in lower middle income countries with a lower dose of this medication and really with 0 bleeding scores and much better quality of life than the use of traditional IV-based clotting factor therapies. And so the World Federation of Hemophilia, with the manufacturer of emicizumab, has now added Emi to its list of medication as part of its humanitarian aid program. So this is my last slide, and I'm sure I'm running out of time. But I think capacity building and access to hemophilia care is absolutely possible in lower middle income countries. One has to be innovative. One has to think a little bit about outside the box. Early diagnosis via education, innovative treatment regimens using maybe modified factor and non-factor replacement therapies, enterprise initiatives among various stakeholders will improve outcomes. And there are many organizations working at grassroots, local, country, and global level to improve care for these patients. I think, as I mentioned before, local and international groups that are conceived and grown by individuals and families with people with hemophilia. So really patient advocacy groups play such a critical role in progressing the care of these individuals. And successful outcomes for chronic disease, ultimately, when the governments realize that this is something that is possible and successful, then they will allocate resources and money to these diseases. And that is the end of my session. Thank you very much.
Thank you so much, Dr. Kaicker. And I'm delighted to introduce our next speaker that I have here, Dr. Professor Leon Tshilolo. He is a professor of pediatrics and hematology at Uficial University. I'm sorry, I should have practiced it. Mbujimai in Democratic Republic of Congo and a visitor teacher at University of Kinshasa and University of Lubumbashi. He is the director of the Institut de Recherche Biomédicale, One Health Association of Sefa Monkol in Kinshasa, He has dedicated most of his research activities to sickle cell disease. There are so many more things I could tell you about the amazing impact Dr. Tshilolo has had, but I'm going to hand it over to him so that he can share with us on the topic of increasing hydroxyurea utilization throughout the world. Over to you, Dr. Tshilolo.
Thank you very much. It's a real pleasure for me to take part to this meeting. And I'm glad to share with you our experience in the use of hydroxyurea in the sub-Saharan African countries. Next slide, please. As we know, WHO retained between the essential medicine for children the molecule of hydroxyurea, but unfortunately is not so used in many of the African countries. It's very important to highlight the fact that hydroxyurea is an essential drug for children suffering from hemoglobinopathies. Next. Next slides, please. Hydroxyurea, as we know, can offer multiple benefits to sickle cell anemia patients. We know that it increased the HbF level and it introduced a mild myelosuppression that is very important. And another action is in reducing the cell adhesion. It make better the blood flow, and hydroxyurea increase the NO, and also it interferes with the endothelial cells. So, and recently there are some studies that think that hydroxyurea have also an immune modulatory effect. As you can see on this slide, before using hydroxyurea in the slide, we can see many sickle cells. But after the use of hydroxyurea, the slides change and we don't see so many sickle cells. The next slide, please. So, when we look in the literature, we can say that hydroxyurea now is mainly used in the north areas and not so much in the low and middle income countries where the burden of sickle cell disease is higher. So we need to enhance the use of hydroxyurea by education and training of health workers, but also by increasing the public awareness so that hydroxyurea will be affordable and accessible. Next slide, please. I will try to share with you our experience on the use of hydroxyurea in 4 African countries where malaria is endemic and where people is poor, globally is poor, and where malnutrition is evident in most of the children. So this experience called REACH was conducted by Dr. Russell Wire from Cincinnati Hospitals in USA. This study concerned 600 children aged 1 to 10 years. Next slide, please. The 4 countries are 2 in the east part of Africa and 2 in the west part. And these results have also an advantage because we have got a good retention of our patients. Now I can say for more than 8 years. That's a good result of retention patient in a clinical trial. Today, we can say that we are giving hydroxyurea at the MTD of 28 milligram per kilo per day. So it's one of the highest posology that we use here in Africa. Next slide, please. We can see that the next slide, please. The use of hydroxyurea offer clinical benefits. So globally, we can say all the sickle cell events were reduced. We reduced also the painful crisis. We reduced the prevalence of acute chest syndrome. And what we did not think that it will be an impact, we also observed the reducing of malaria events, the reduction of need of blood transfusion, reduction of death, reduction of absenteeism, and globally, we can say that we have got also a reduction of financial costs of the sickle cell patients. The next slide, please. So the next one is Russell 1. So we also observed that in patients with abnormal TCD, or we observed that using hydroxyurea, we reduce the risk of stroke, because in most of the African countries, it's very difficult to introduce a chronic program of blood transfusion because of high risk of viral infections due to blood transfusion. So our experience displayed that hydroxyurea contribute to the neuroprotection in sickle cell patients. The next slide, please. I would like just to spend 2 words on the impact of hydroxyurea on the prevalence of malaria. We observed that this was due to the reduction of the number of neutrophils. Our results display positive impact when the number of neutrophils was less than 3,000. This is a very interesting result. Anyway, even though we don't understand all the mechanism and the reason why the reducing of neutrophils contributes to reduce the burden of malaria in sickle cell patients. The next slide, please. Hydroxyurea works so well. So now what's the problem? There's another problem due to the interpatient variation in dose and in the response of the patients in producing HbF. So is the reason why now we are working by using the pharmacokinetics of hydroxyurea so that we can start immediately with the best MTD dose for any patient. Because at the beginning of the study, we increase progressively the dose of hydroxyurea, but now we have changed the system because of the capacity to use the pharmacokinetic data. And now this is an advantage impact because we can plan the MTD dose for each patient. The next slide, please. Yes. So why in most of our low-income countries, hydroxyurea is not so well used? First of all, I would like to suggest 3 modes of use of hydroxyurea. We can use it at the low dose. It was demonstrated in India and in Nigeria that even with low dose of 10 to 15 milligram per kilo per day, we observe good results in the use of hydroxyurea. And this policy, I suggest to use it in the remote areas where there are no doctors, where there are no lab for the follow-up of the lab event and so on. Using the low dose, it also offers the advantage to give hydroxyurea to a great number of patients. The second model of use of hydroxyurea is the standard dose, with the dose between 20 to 25 milligram per kilo per day. And the best one is, of course, the maximal tolerated dose. Actually, the maximal tolerated dose in our experience is 28 milligram per kilo day. We can go to the maximum of 35 milligram per kilo day. Next one, please. So why we have a so limited use of hydroxyurea in most of the sub-Saharan African countries? One of the main reasons is due to the cost of hydroxyurea. It's too expensive because, for example, in Central Africa, one pill of 500 milligram is $1. It's too expensive, while we know that in India is only 1 cent. So we need to find solution to reduce the cost of hydroxyurea. Another reason of limitation in use of hydroxyurea is due to the fact that in the box, in the leaflets of hydroxyurea, we don't find the specific indication for sickle cell disease. And many of the doctors and nurses, when they read the paper in the box, they said hydroxyurea is a drug for cancers and not for sickle cell disease. We hope that these lack of specific leaflets on sickle cell disease will be reduced. Of course, we have also a lack of education and training of health workers. And the last one, the last reason of limitation of the use of hydroxyurea is due to the fact that people is afraid of the hypothetical effect on sterility, on fertility, and on teratogenicity, even though the recent papers in France displayed that they have not observed any teratogenic impact in women who in pregnant women, we use hydroxyurea. The next one, please. So in conclusion, we can say that hydroxyurea is really well tolerated and effective in improving hematological outcomes, biological outcomes, lowering the pain crisis, and even lowering infectious events, specifically malaria events. And hydroxyurea prevents stroke risk. Hydroxyurea is also effective and safe in young children age less than 1 year. I think that in the USA, they start to use hydroxyurea by 9 months of age. So we think that the use of hydroxyurea will contribute to reduce the need of blood in many of the African countries. And we suggest to use the 3 models: low, standard, and MTD dose. And the last one is just to thank you very much for your attention. And I'm grateful to all my collaborators that contributed to our experience on the use of hydroxyurea. Thank you very much.
Thank you so much for that excellent presentation and for all the work that you have done and continue to do to increase our access to hydroxyurea across the world. It is now my pleasure to welcome and introduce my colleague, Dr. Ziad Solh. He is a hematologist and transfusion medicine specialist at London Health Sciences Centre in Canada and an assistant professor at Western University. He currently directs the Adult Red Cell Disorders Hematology Clinic at London Health Sciences Centre, where he sees patients with sickle cell disease and thalassemia, and he is the head of the transfusion medicine division in the laboratory. Today, Dr. Solh will be speaking with us about increasing access to iron chelators in beta-thalassemia major.
Thank you, Dr. Verhofstadt. Sorry, I was trying to find my unmute button. It disappeared when I maximized my slides. Thank you so much for the introduction. I'm really excited to be here to present about the iron chelation access and what we know about it so far. So my objectives today are really to quickly go over why it's important to chelate iron or remove iron from patients' bodies with thalassemia, and what are we encountering as barriers and potential opportunities for accessing these chelators. And as we all know, beta thalassemia major patients are transfusion dependent, such as we see in this picture. There are large clinics that infuse blood, but this blood has and if we don't give blood, it can lead to a lot of consequences. So it's an essential part of their therapy. Unfortunately, inside of this blood, the hemoglobin, which our patients need, has iron in the form of heme, which is this highlighted in the blue box. So really, we can't get away from getting the iron infused into our patients. So getting access to iron chelation medications is really crucial. The issue with iron overload is that the longer the iron stays in the body, meaning duration of exposure, the higher the toxicity. We know this from several studies. It is also impacted by other things like antioxidant genetics, which we really can't change, dietary antioxidants, but really the very modifiable factor is the iron overload piece, and this is leading to labile plasma iron, which causes tissue damage in many ways. We really can't get away from iron overload even if we do not transfuse. So iron overload can happen in a transfusion independent manner through a mechanism that I won't go deeply into, but it involves erythropoiesis inhibiting hepcidin, meaning blood production ineffectively happening, which ends up inhibiting hepcidin, affecting iron absorption through the gut. And this leads to iron depositing within the heart, causing sometimes sudden cardiac death. It can lead to iron overload in the liver, causing liver cancer and liver cirrhosis. The pancreas is quite sensitive, leading to diabetes and a lot of other endocrine disorders. So really, we can't really highlight enough the importance for access to iron chelators across the world. Complications, again, more subtle, but they can even involve infertility, sexual dysfunction, hypothyroidism, even arthropathy. The list really goes on. This highlights that the table highlights at least the benefits of iron chelation. This is a very an excellent paper that really demonstrated that in the 1970s, a lot of complications were super common, whereas in the 80s, when chelation came on the market, it really helped improve the prevalence of hypogonadism, diabetes, hypothyroidism, even death. So access to iron chelators cannot be stressed enough. I'll also highlight that even patients with sickle cell disease can be iron overloaded. We all know that transfusion is a disease-modifying therapy in sickle cell disease. So although my talk's on thalassemia, I really think it's a hemoglobinopathy-wide issue with access to iron chelation. Barriers, we think of barriers often as cost and funding barriers, but really, a lot of the literature highlights that it is a matter of adherence and removing access barriers for our patients that have to do with the ability to even tolerate the medication. So, in Canada, we have something called the Exceptional Access Program, which comes in very useful when we encounter situations where we need more than one iron chelator, so 2 medications rather than just one. And we are fortunate to have these governmental programs focusing on patients with thalassemia that need it. And around the world, there are, this may not exist uniformly in all countries. What I want to also focus on is the issues with adherence, where a lot of the literature is really happening currently. The Zoom is blocking one of my slides here. But this was a recent paper for 2022, looking at a systematic review of 44 different papers, and really overwhelmingly, the evidence is that we need to provide access to oral iron chelators, not just the first one, which was the most effective one, the most efficient one, the furoxamine, as we all know. So this is something we have to think about, knowing that the evidence is that oral iron chelators are preferred by our patients, and really logistics of getting IV or subcutaneous iron chelation is very marred with many barriers. It's another paper from Malaysia. They did a qualitative assessment and interviewed patients and asked them, what are your barriers to accessing iron chelators? And really, a lot of them are, patient-related barriers where, it might be them thinking about their medical condition due to the several social determinants of health, but a lot of them are medication-related barriers like adverse events, socioeconomic related factors, and perhaps there were not clinics well set up to optimize the patient healthcare provider relationship. So really, the barriers are many, and these do impact the access. So it's, a lot of it's not necessarily cost itself, but about the medications themselves. Facilitators, though, are also present, which is wonderful. And really, educating patients and patients having their own insights about what they want in a medication has been a facilitator. Lots of some countries have ability to cover some costs, and a lot of the medications are safe, especially the ones that have been well studied. And then, of course, the social supports, having social workers or a good social network for the patient to support them throughout their chronic disease. Now, when we think about what is the ideal iron chelator that will optimize adherence to its administration, really we think about, does it even work? So it has to bind iron efficiently. It has to be a strong binder to iron, but also it has to remove the iron. It has to have the ability to come out of the body, either through the gut or through the urine. And then, of course, it has to be inexpensive, or at least if it's costly, we have to have a structure to cover its cost. It has to work for a long time so that the patient isn't having to take it constantly. So a long half-life helps, and I'll talk a little bit about some novel chelators that are not daily, which is really, really important for our patients. And then orally administered instead of IV, palatable, so it tastes good, it doesn't bother our patients. We know that certain chelators have to be put in a solution which really works for patients that cannot swallow pills, like children, but it may not taste good. So, I think more research has to happen to improve palatability of the medications. And then we want it not to harm our patient and not to cause significant side effects that'll either make the patient not enjoy the experience or make us worry about their health in other ways. Obviously, the less desirable is the opposite of all of these things. This is what we have currently on across the world. And this is from the Canadian Hemoglobinopathy Association's consensus guideline, which was updated a couple of years ago. And really, it shows that we have 2 iron chelators and 1 subcutaneous and intravenous. It's really wonderful that the furoxamine works very effectively. However, it is IV infusion, and it has to be constantly administered as soon as you shut off the infusion, it really stops working within 20 minutes. And there's research happening on improving half-lives of these other chelators, like the ferroprone and the ferrosirox. This is one of the barriers. I mean, we want to keep our patients safe, but at the same time, it is a burden on patients to have to do, weekly CBCs in terms of the ferroprone causing granulocytosis, or a lot of the monitoring. It's essential. I'm not saying it's not essential, but it does add a burden to our patients' busy lives. What is new and exciting is that the ferroprone, there is now a version that is not 3 times a day. It is twice a day, and that's been well received by patients. That does improve access, that does improve the patient's experience. There's also a novel iron chelators that's in study right now. It's not yet available in general, but it's not daily. It has a longer half-life, so it's only administered 3 times a week, which patients would probably appreciate. And then, dual iron chelators, it's not really new, but it's something we would consider. And I think there's less funding barriers at least in North America, that I think we need to improve access to the rest of the world. That's the end of my slides. I realize we have 5 minutes. I thought I'd reserve that for questions.
Fantastic, and I appreciate you really catching us up on time here, so we do have a few moments for questions. There are 3 questions listed in the chat, so I'll read these out. The first one is for Dr. Tshilolo. What is the reason behind the cost disparity between countries for hydroxyurea? You had mentioned, for example, some very low prices in India and higher costs elsewhere.
Yeah, thank you for the question. That's the problem. I think that first is due to the fact that India is able to manufacture hydroxyurea locally. The second reason is the high cost of customers in the African countries. And I can say another reason is due to the fact that globally, people is very poor. I can say that people is living with $2 per day, and it's too expensive, the cost. Even we say that they can buy it at $10 for 20 pills. It's too expensive for people who are poor. I think that are the reason why we have not a great use of hydroxyurea in most of the sub-Saharan African countries. Thank you.
Thank you, and I think just looking at the next question, this is really to you as well, related to sickle cell. This person's sharing their personal experience of asking their hematologist if they should start hydroxyurea. The hematologist said no, as your sickle cell is not severe and you've not had pain crises for many years, you don't need it. Just continue with whatever you're taking now. Is this right? What are the indications for hydroxyurea from your perspective, recognizing that this may be a very big question?
Yes, indication of hydroxyurea in sickle cell patients is just sickle cell disease. Mm-hmm. Because we observe that even those who have no many crises and so on, those who are submitted to hydroxyurea are better than those who are not submitted to hydroxyurea because they have not got many severe complications. So for me, hydroxyurea is a drug for all the sickle cell patients.
Thank you so much. Well said. With the short time we have left, there's a very excellent, really more of comment and feedback by David Ogoro. So I'll ask my colleague from GANSID to please take down his contact information. He's providing feedback about being a sickle cell warrior and also being deaf, and also needing, therefore, to have good access to information, good access to these conferences. And so I'll ask my GANSID colleague to please take down his contact info to support this. And then I'll move on to the last questions, which are related to chelation. Number one, deferriprone twice-a-day formulation approved. Where is it available? And maybe while you're answering that question, Dr. Solh, the other question, sometimes different iron chelators are not responding to certain patients, and combination therapy also doesn't always work. What's the reason for this, and how can we overcome this crisis? In 1 minute, how would you best support the question?
I would say, oftentimes when we see chelators are not working, it's the patients are not adhering to it, though they report that they are. And we involve a lot of resources to try to improve this. So we have a clinical navigator that actually meets with the patient separately outside of clinic. And often they discover patients are not taking it just because they, not cost necessarily, it's just they are teenagers or they are young adults that have busy lives. Also, twice-a-day formulation, at least in Canada, was approved. I don't want to mention brand names necessarily, but it is called Feriprox MR, Feriprox modified release through Chiesi. So CHIESI is the manufacturer, and we just got it approved by Health Canada within the last 6 months. So it may not be worldwide just yet.
Thank you so much. And I think for most of our attendees, a closing poll has popped up. I feel as though we really could have used so much more time to answer some of these questions. I'll highlight a question here about the lack of label indication for hydroxyurea for sickle cell that Dr. Tshilolo brought up. And Josie has also flagged as a question about how can organizations such as GANSID address this gap and address this regulatory hurdle. So I think this is really an excellent question and perhaps a call to action on this important topic. I'm going to turn things over to, I think, our GANSID colleague, and otherwise we will be shifting over to the next session. Thank you so much to all our speakers today, and have a wonderful rest of the day in today's Congress.